So good morning, everyone. So we are having today's session on ethical considerations in health policy and systems research, principles as well as practice. So this particular session, I will be talking mainly about the principles and the kind of developments which happen around ethics in health research, particularly globally and then specifically in India. And my presentation will be followed by Karina taking over, sharing examples and arguing about HPSR in everyday ethics, and that will be then followed by Solomon talking about sharing his examples, doing a field work, okay, and the ethical issues while doing that. So first thing first, let's start with this particular open question. Generally, when we talk about ethics, okay, we have a shade of morals into it. So ethics and morals, some people are using interchangeably, and we really need to know what is the difference when we refer ethics as well as morals. And most important question here is whether we need ethics or morals or both when we are going for doing studies following a health policy and systems research methodology. So here we have elaborated a lot on ethics, which is a kind of rules of conduct going by one's culture or group, and generally ethics has been observed by external source or a social system. So what kind of examples you could give when it comes to ethics? Rules of conduct in particular culture or group. Any particular thing you want to? Yes?
Maybe for example, if we are taking IT sector, they have sort of an influence of the Western culture operate as an organization.
Yeah.
So they frequently have get-togethers, but there's a rule of conduct in terms of hierarchy, how it is conducted. That
So yeah. So
their social system.
so you know.
It's not so much a social system, where it's a bigger context, relevant for IT.
Yes.
IT and information in general.
Yeah.
That is
Yeah.
The confidentiality of information when comes to users, for example. So the ethical part is you have to keep their information confidential and not allow any breach.
Okay. So this is something in relation with confidentiality. Okay. Anything further about ethics? Yes.
Whenever we do something, if like we are conducting some research on or studying some groups, so there whatever we are studying, just telling our participant to some introduction about our study, so transparency between both, so that which
So you are in a way referring to in sharing of information with the respondents, or
no,
how it is?
the
Whether that is only ethics?
introduction of our study, so that they also know that what we are studying.
Okay, so giving information about the research, what you are doing,
Yeah.
but that is just one part. Yeah, then moving. Yeah, any other?
It is something like it may be research or it may be any ongoing process, like how we consider the participants or public, like in terms of respect or in terms of like suppose if we are doing something in a process, that in that process some other may get affect like in some other way. So we have to take like some precautions or something so that they should not get hurt in terms of anything like in like in terms of like psychologically or physically or something anything. So by considering all those things we have some principles or something we like a culture we need to follow that
Yeah.
can makes sense
So
to our
ethics
people.
is something, according to you, is going by certain principles.
Yes.
Yeah, and one of the principle you refer to is harming, not doing harm to others.
Others.
Yeah. Any anybody else?
This becomes especially relevant when you're working with the marginalized populations.
Uh-huh. Yeah.
Yeah, because
Yes.
they aren't going to be forthcoming to you, and you have to follow the certain rules of ethics and moralities, which they perceive as. And as a researcher, we have to be very careful about these things. Unless and
Yeah.
until we are able to do some good research that won't translate into policies, that's a
But
main
whether ethics and morality is same or they are different?
no, they are different.
Okay. And then whether we have to consider only ethics or only morals?
Both of them.
Both of them. Okay. How one can do that? In which way? All of you are experienced doing research for so many years. So how we can do that? Yes. Yes, Vivek.
There's one thing that I think benefits should be more than the harm. If we are conducting a research, then we should also look that if we are doing some research and we are implementing something or intervening something, then we should look at whether they are getting more benefit or not, or whether harm should be less. And also we should look at the consent. We should take the consent of the people.
Yeah.
So that is one thing.
But is it always that our research would lead to immediate benefits?
No, it can't be that way. Like
Yeah.
it can take time. Depending on the strategies, it can take time. So it can't be immediate. However, it gives a sense that sometimes it can give a sense that something has started. So initial steps has been taken.
Yeah, so listening to all of your reactions, I think all of you tend to speak more about the ethics than morals or so-called morality one should have as a researcher. Okay, and the thing is that the kind of a intermix of both ethics and morality and the kind of a unclear kind of a distinction, or there's no distinction between the two going by most of the researchers, but going by this kind of a definition which is listed here about morals, what are your reflections? Whether ethics is important or morals?
I think both are important. But if we look at the from human side, then moral gets a slightly higher rank. But again, ethics also plays a equal role. So it should go hand in hand.
Okay, so yeah, just referring back to our health systems theory about control knobs, whether you will see that as knob today, more ethics, less moral, more moral, less ethics. How you would like to go about considering that?
Thinking about the question where you might have a situation where guidelines for ethics conflict with personal and moral values.
Yes. Yeah. So that is what makes this particular kind of subject more interesting, as well as the importance of considering ethics in research. So we really need to keep in mind the interrelationship, who is controlling what, and invariably the kind of a distinction between both the things. Let's move on and This is what we are going to cover today in this particular session. And let's start the entire kind of guidance for ethics in research which is available. Mostly it is available. The story started way back with war crimes, and that's the reason the Nuremberg Code in 1947 came into picture. These particular kind of discussions on ethics in doing research with human participants actually also got reflected into United Nations International Covenant on Civil and Political Rights way back in 1958. It was followed by World Medical Association's famous Declaration of Helsinki. And time and again, so Declaration of Helsinki actually drafted in 1964, but time and again there were a number of modifications in view of the changing situations, the kind of increasing challenges around ethics. And what we got now, the latest revisions in this Declaration of Helsinki happened in 2024. So we have to note all these particular things. So one thing is not actually, once you draft the guidelines, once you prepare the guidelines, okay, so it is, all these guidelines really need to be, actually they have, what we observed is that all of these guidelines have a evolving kind of a nature. For example, also we are finding this Council for International Organizations of Medical Sciences, CIOMS guidelines as they famously called as. So this is the agency which come up with this international ethical guidelines for health research. So 2002 they first drafted it. There were several revisions, and latest revisions are in 2017. So as this global kind of evolution in the guidance for ethics in research is happening, we can see this reflected into our national guidelines for ethics. So this is the kind of a history of biomedical and health research ethics in India, the kind of important documents. So I have listed here 5 documents. Okay, so as the entire world is thinking about what we should have, okay, what ethics we should have, what ethical practices we should go for, way back in 1980, okay, there was a policy statement coming from Indian Council of Medical Research on, this was policy statement on ethical considerations, okay, and that is about research on human subjects, okay, 1980, okay. Here I want to highlight the word human subjects, okay. In the year 2000, Indian Council of Medical Research, okay, going beyond policy statement, for the first time formulated guidelines for doing biomedical research again on human subjects, okay. So consider this. And then around the same time, some of the activist organizations, they were feeling not so comfortable with this so-called biomedical research guidelines dictating, okay, the overall research scenario in India. So what they actually have done are that they thought that, okay, in India we should have parallel guidelines, okay, which will look after entire social science health research. Okay, so they constituted one National Committee for Ethics in Social Science Research in Health, okay, and this entire exercise was facilitated by SEHAT, that is Center for Inquiry into Health and Allied Themes. Okay, so they for the first time come up with these ethical guidelines for social science research in health. So this particular thing, okay, so we in India, in the year 2000 to 2005, we used to have these 2 kind of a separate guidelines being followed. Aware that at the same time, we are not having so-called institutional review boards or institutional ethics committee. They were not formed till 2006, okay, ICMR ethical guidelines for biomedical research, and for the first time you will find this change in the word, human participants. Okay, so rather than considering them just as mere subjects who are supposed to passively participate into research, for the first time, okay, they have been brought at the equal level, participants. Okay, so this particular change really stimulated lot of kind of acceptance of all these ICMR guidelines. Then they actually slowly they started promoting the development of institutional ethics committee and so-called institutional review boards in various institutions in India. This particular process was slow to start with, but eventually it spread to entire India. And then it comes the latest document of ICMR of 2017, in which we have this national ethical guidelines for biomedical and health research. Going by title itself, that shows what is going to be there. Okay, so far we were just having biomedical research guideline. Now what we have is biomedical and health research guidelines, and another important thing, change in the way we were doing some things, that is involving human participants. Again, going beyond passive acceptance, we are now thinking about involving human participants, and that is what is clearly reflected throughout this particular document. So in this particular kind of a history, we are seeing 1980 to 2017, it was kind of an evolving document by Indian Council of Medical Research, which is supposed to take care of entire ethics issues, okay, involving human participants. Okay, but what happened in 2017, that there was a kind of a need for having separate guidelines involving research with children. So that particular document also got formed, and then what that particular document, it was not a kind of a parallel document, it was just adding on to this particular document. Then comes 2020, okay, once in a century pandemic, COVID-19. That really actually compelled us to rethink about these long procedures, because in the pandemic situation, you have to act fast, you have to do a kind of a fast research. And then if we keep on waiting for ethics clearance, it was not possible. So most of the researchers in India were struggling. So around that particular time in 2020, okay, ICMR floated guidelines of biomedical and health research during COVID-19. So these all things, so 2 or 3 separate documents we can see published by Indian Council of Medical Research, okay, to tackle COVID-19 kind of research priorities. The journey continued, and 2023 also we have certain guidelines. Then latest is ICMR come up with now ethical guidelines for integrative medicine in this same year. So, but consider these not as separate documents. This is just kind of adding on to the present 2017 National Ethical Guidelines for Biomedical and Health Research. Going further, all these documents, let it be global or national, they are highlighting on these 4 core ethical principles. Okay? First and foremost principle was non-maleficence. Research must not cause harm to the participants in particular and to people in general. That is the first core principle, followed by principle of beneficence. Research should also make a positive contribution towards the welfare of people. Third, principle of autonomy, that research must respect and protect the rights and dignity of participants. And last but not least, very important, is principle of justice. So we really need to be aware about the benefits and risks of research should be fairly distributed among people, and that is what is these core ethical principles are all about. These 4 core ethical principles considered as the kind of a basis to come up with more kind of a general principles, okay, of ethics in research. So our national document, okay, has listed all these 12 principles of ethics in research. So most of these are self-explanatory. Principles of essentiality, okay. So what that actually demands from participants that, or from researchers, sorry, not participants, it demands from researchers when there is need, okay, when there is no essential information available, then only you should go for doing research. That is the first principle of essentiality. Principle of voluntariness is, of course, concerning participants. Principle of non-exploitation, yes, you should see that your research should not discriminate, okay, should not exploit anybody. Principle of social responsibility, and this rests with researchers, okay. Your research should not cause undue social unrest or social disturbance. So that is your responsibility being a researcher. Principle of ensuring privacy and confidentiality that everyone is aware about. So I will not elaborate. Principle of risk minimization. This is concerning participants mainly in clinical trials. Okay, we have to go for risk minimization. So that is a kind of a very important principle. Then professional competence. Yeah, this is concerning researchers having skills, necessary capacity to do certain kind of a research. Then maximization of benefits is towards participants. Institutional arrangement. So we really need to, okay, have a kind of a supportive environment for doing research, whatever infrastructure is required. Okay, so we really need to have that kind of a institutional arrangements to have that. More important thing is about transparency as well as accountability. So all these things are concerning participants. You should not hide any information. Okay, you should not hide your intent or purpose of doing certain research. So you have to maintain that particular transparency, but it does not stop at the participant level. You have to think about when you are publishing your reports, okay, they really need to be available in the public domain. Okay, so that particular transparency and accountability. So certain journals now, research journals, expect you to put your data into their repositories. So data repositories is also important. So that is your accountability. Okay, principle of totality and responsibility. Throughout the research, all stages, you really need to go for that particular thing. And very important principle that while you are conducting or doing research, you should take, okay, care of all environmental issues. Okay, so remember this connection between 4 core principles guiding these 12 general principles of ethics in research. Any kind of doubts or questions about this?
So Abhay has just given us an overview of ethical principles which all of you will have encountered at some point in your studies or in your training. You're familiar with them, yeah? But often it's less clear exactly how they're operationalized. And especially given that it's a very tall order, okay, to have ethical principles which across the world are going to be operationalized in the same way. Why do you think this might be challenging? Okay, going back to our first question that we posed to you, which is the difference between ethics and morals. Ideally, they should be separated. Okay, but what happens if I'm implementing guidelines around consent in India and in Finland? I don't expect you to be familiar with Finland. What do you think is going to happen? What are the local level discussions that need to take place? Do you think consent means the same thing everywhere? Okay, some of you are saying yes, it should. Some of you are saying not sure. And some of you are saying no. Any idea?
It depends on what kind of value they are associating with consent and what kind of culture they're coming from. That's why I'm a little unsure of whether consent has the same definition all around the globe.
Okay, good. So sometimes, even though you have principles on paper, and even if you have national level research committees that tell us how we should be respecting these guidelines, it's a bit less clear when we get to actually interacting with our research participants or implementing those guidelines in the field, because people have different understandings of what consent means. Okay, and maybe in some places, it is the norm that individuals make decisions on their own. Whereas in other places, those decisions that people make are heavily contingent on, it's a dyadic society, which means that they're contingent on specific social relationships. They could be family, it could be the partner, there could be some gender issues involved. I think I already mentioned this, before. So we're going to get into this a little bit. Okay, this thing is frozen, but let's hope it moves. So just bearing that in mind, okay, I would argue that this holds true for any kind of implementation of ethical guidelines, regardless of whether we're talking about clinical research or biomedical research or health services research or health policy and systems research. But I think what's nice about health policy and systems research is that more than in clinical research, we're allowed to discuss this openly. We are allowed to discuss why it's a bit more challenging to think about the very strict guidelines that we're given when implementing them in the context of a research that involves different kinds of actors, different kinds of dynamics, and different kinds of settings. So I'm going to argue that health policy and systems research introduces unique ethical challenges, which make some of the principles that Abhay has just shown you a little more challenging to think through. Okay? Why? Because we're focusing on systems, policies, and organizations. These are actor-driven. Yeah? And we've said from the beginning that what's interesting about health systems is not so much the medicines, the technologies, the infrastructure. It's the people within. It's a people-centered approach, allows us to understand that the social is deeply intertwined with the infrastructural or the technological. And it's those interactions between the guidelines that underpin people's behaviors in health systems and the technology, infrastructure, resources that are available to them that's of interest. So in this inherently kind of human space, we're thinking about both ethics and morals in some ways. The other thing that makes it challenging is that both public health research as well as health policy and systems research is often concerned about communities. And now we said not just communities outside of the health system, but even communities within the health system. The community of ASHAs, the community of private providers. So that is a different thought about ethics beyond individual level consent, confidentiality, etc. Right? So the other thing is research and practice are commonly intertwined. So if you think about the type of research that we spoke about briefly during the session on evaluation, a lot of health systems and policy research is about interventions. Implementing an intervention in a real life system and seeing what happens. Is it making a difference? Is it improving performance? Are people adhering to guidelines more? Yeah? But sometimes it's difficult to separate. It's not like we can have a test tube health system where everything works like a robot, where everything is sort of like, I don't know, those movies where, people are programmed to behave in a certain way. No, if you want to find out whether something's going to work, you're going to have to implement it in the context of a real life system. And people aren't robots. Yeah? People aren't robots, and neither is so what's happening within the internal environment changes, but also the circumstances of the external environment that impact on the health system are also changing. So it's a dynamic environment. It's not a controlled experimental environment. So we need to separate what should be governed by the ethics of health systems practice and policy making and what should be governed by the ethics of research. Let's look at these a bit more closely. In clinical research, often we're looking at a specific disease process and the outcome, right? We're going to study how, the progression of X condition is in populations who have a particular genetic makeup, and we're going to understand sort of what's happening. So we need to abide by certain ethical guidelines when we conduct that research. We might also be looking at the impact of a specific drug in a group of people who we try to isolate. We try to rule out all the other confounding influences so that we can just look at the impact of the drug on the disease progression, right? But in health policy and systems research, that's not our interest. We said that from the beginning. Clinical research is separate, yeah? We're focusing on processes and practices. So it's a different sphere of research. Clinical research, if you're testing a new drug, or if you're looking at the impact of a specific technology on people's, prognosis, clinical prognosis, your study is often conducted, your trials are often conducted under controlled conditions, either observational or experimental. Yeah? In an observational study, you're looking at, let's say you're doing a prospective study, and you are interested to see how people with different characteristics at the outset are evolving in terms of their likelihood to develop some condition. Prospective study, right? You can control through all kinds of fancy statistical techniques. You can control for all the confounders that you want to remove, and you can just look at your exposure, your risk factor, and your outcome. In a health system study, you're embedded in a real life context. This is not an experiment, and the researchers do not have control over those circumstances. So the gold standard for most clinical research is an RCT, which is a randomized controlled trial, which is a very specific methodology that is a way of controlling both the sampling, the recruitment of participants, as well as a way of measuring the outcomes that are attributable to specific factors of exposure, the intervention, the medicine, whatever. In health policy and systems research, we've said that the methods are interdisciplinary, okay, because we're dealing with a completely different kettle of fish. In clinical research, the interventions are implemented at the individual level and often measured at the individual level, right? Whereas in health systems, the interventions are implemented at the systems level. So there might be some things that you can measure at the individual level. Okay, does my motivation of the ashas improve if I provide some training? But in general, you're going to look at that training program as impacting on other parts of the system, because you need to understand whether the system per se is going to be able to implement this intervention, which will impact not just on the digital literacy of the ashas, but it's also going to impact on how other people feel about their training. It's going to impact on the resources available for training and so on. So you have to think about questions of sustainability, etc. Usually in clinical research, the outcomes are measured at the same individual level, whereas in health systems research, the impact is measured at the level of the community, at the level of the health system, or even the institution. So key ethical questions in health policy and systems research differ slightly from clinical research. And I would say that most of what we do in health policy and systems research, each of your topics, if you think about it carefully, challenges traditional ethical frameworks because we're addressing a broader context. We're addressing what we would like to see as some kind of transformation of the system as a whole. It's not going to help if I individually equip those ashas with improved digital literacy, because I need to think about the conflict, the competition with other health workers, what exactly. So we're always thinking about what is the impact on the rest of the system. Yeah. So some questions are raised, including defining the participants. For example, in policy research, which is intended to modify healthcare delivery, who qualifies as a participant? Yeah? Are we interested in individual providers, mid-level managers? Are we interested in the facility and the improvement that we're trying to achieve? Or are we interested in, let's say, that particular unit that is located within a broader system? Okay? So thinking about those hospital level studies, for example, the interventions and the participants could be micro, meso, and macro in the hospital. Okay, so each time you're thinking about ethics slightly differently. There might be there might be important ethical considerations each time you consent somebody into your study. But at the same time, the study is not isolated. It's not an isolated focus on hospital managers. It's understanding the hospital as a whole. The hospital becomes your unit of analysis. Okay, so it's slightly different. In terms of consent, should I be individually consenting, hospital managers, or should I seek some sort of group or institutional level consent? Okay, if I have 8 hospitals participating in my study, I'm doing some quality improvement initiative, is it enough to just consent the managers? Probably not, because my intervention research is going to involve hanging around the hospitals, observing lots of people, conducting many different types of interviews, maybe doing some structured work. So I need to think about consent differently as well, right? The next thing is about protecting groups. So because health systems research often has broader impact on particular communities, we need to think about who is advocating for the communities, the organizations, or the health systems that are impacted by research. So the questions of protecting the informant in a classical clinical research where you're advocating a new drug, you have to look very carefully at the individual level side effects, the risks, the benefits, what this means, becomes a bit more complicated when you're thinking about a health systems intervention, because there will be different communities impacted by your research. Okay, so in the road traffic example, you might have direct recipients of the research or participants in the research who are at the level of the trauma center, but you also have the people who were affected by accidents, who received timely care or didn't receive timely care. You might have some kind of lobby group which works on behalf of junior medical staff who are overburdened because they're not coping up with and they're not skilled to provide that trauma care. So the question of individual level protecting people from doing no harm or protecting them from risks becomes more complicated. Yeah? Similar to the next question, so how to outweigh or how to weigh the potential benefits against risks for individuals versus groups. Because you are dealing with both the individual, but you're also dealing with the group or the mini unit that they belong to. And then the last question, which is specific to health policy and systems research, is, ideally if you're doing a clinical trial and you want to introduce a new drug, and you're saying, I want to introduce it, I want to now introduce it into the health system, you want something to lead to a measurable change. You want the thing to be sustainable. You don't want to introduce a drug just for the sake of testing whether this shorter regimen works better than the longer regimen. It's because you truly believe that the shorter regimen is going to improve systems efficiency, it's going to reduce patient suffering, it's going to make the whole system work better. But the question is that not all interventions have sustainability considerations. Okay, so that is something when you're doing individual level research, the question of individual level sustainability is less of an issue because the person who has the condition, there may be a specific lifespan associated with that condition. or a specific duration of time, right? Versus you introduce an intervention in the health system, you want it to last, right? You don't want it to just run out after the end of the intervention period. So let's look at an example. So if we're trialing a new method of service delivery, let's say we're integrating TB and diabetes care at a hospital level, your hospitals might be randomized. Yeah, you might randomize hospitals in order to select them, but your health providers are going to be affected by this randomization, the choice of the health providers. But at the same time, you're going to collect data from patients. So there's 3 kind of different levels that are going on in this research. You're selecting hospitals as your case studies, maybe, or sorry, I said that's not the case study. The case study would be the mode of service delivery. You've got hospitals, but now you're looking at health providers within the hospitals because you're trying to understand the readiness of those hospitals to deliver some form of integrated care. And then you want to see whether the impact of the integrated care made a difference to the patient's management and progress on their treatment. So the data is being collected at different levels, right? If it's such a complex study, who's considered a participant? Is it the patient or the health provider? Are hospitals somehow non-human research participants? Who do I take informed consent from? Yeah? And under which conditions would you waive the consent requirements? Okay, so it's infinitely more complex, or at least you have to think about those things. Let's think about each of the 4 principles separately. So autonomy is about each person's agency to decide whether or not they want to participate in the study. In clinical research, that unit of study or that unit of analysis is an individual. In health policy and systems research, it could be an individual, but it could also be an institution or a community, right? Consent is usually taken at an individual level. Here, we could be taking consent at an individual or a group level, right? Clinical research, we don't really consider gatekeepers. What is a gatekeeper? Anybody know what a gatekeeper is? What's meant by a gatekeeper in research? Yes? Yeah? Yeah, absolutely. So just repeat that for the camera.
So gatekeeper are those basically who introduce us to the community. For example, we are being a researcher, so if an ASHA facilitator is a gatekeeper for us to communicate or engage with the community.
Yes, exactly. Doesn't have to be just the community, okay? Don't make the mistake of thinking, again, we only need gatekeepers for the community. Very often it's the opposite. We need gatekeepers to get our way into the system or to introduce us to some official in WHO. You'll need gatekeepers everywhere. Basically, those are the in-between steps. So for example, we did a study on HIV in a rural community with the organization that Abhay and I were working with before in Pune. And in order to really be able to talk to families who had 1 or more members affected by HIV, we thought that the best gatekeepers would be the providers in the area. Now, obviously, this was ethically quite challenging because we had to respect consent, confidentiality, anonymity, but those providers were asked to be gatekeepers for the study because we said, if you have people who are affected by HIV or families, can you ask them whether they would be willing to participate in the study? Okay, but that raises lots of issues which we will discuss later. But in any case, a gatekeeper in a clinical study is generally not required. You want to have direct access to the people who are your subjects or your participants in terms of understanding their perspective on whatever it is, their treatment, how they're feeling, their adherence, whatever the outcome of interest is. In the health policy and systems research, often the gatekeeper is chosen to facilitate your research. So it could be a person, it could be an institution, it could be a representative of some organization. Let's look at this example. It's a project which is studying the integration of maternal health services And it's trying to collaborate with community health workers and local women's groups. So the researchers are working closely with people who are both gatekeepers, but they're also people who, if this intervention is meant to work, are going to be instrumental, going to be very important for its success. So the researchers build in a mechanism whereby they have regular feedback sessions with these local groups to share their findings, gather insights, and they're going to adjust their study design based on community input. Okay, so this is what we started to talk about kind of when I think Solomon was giving his lecture about how this is one way of engaging the community, okay? The community here is represented by a particular group, okay? CHWs on the one hand, who might be more aligned with the system, and local women's groups who might be more aligned with the community. But I like the fact that they brought the two together, yeah? Okay, second principle, do no harm. In this case, sorry, the title is missing. On the left-hand side, it should say clinical research. The focus is often on the risk for the individual participant. In health policy and systems research, the recipient might not be the same as the beneficiary. In other words, you implement a health systems intervention in the research, but actually your intervention is going to benefit a different group of people because you're not necessarily tracking the same people. You're introducing a systems level intervention, and you hope that in a year's time, people who have TB and diabetes are going to be better served by the system. But you're not tracking baseline and what happens after that, okay? The risk to the individual in clinical research should be acceptable relative to the potential benefit. Yeah, you always do that. You always sort of say, okay, there are some risks associated with embarking on this treatment regimen. Hopefully they're temporary side effects. They will not cause you, any long-lasting effects, et cetera, et cetera. The potential benefit if we can really implement this drug at scale it up, are going to be higher than the risks, right? Whereas in health policy and systems research, the longer-term risks or the unintended consequences might not be recognized. So there are lots of examples which show you that reforms that were very well intended, okay, things like pay for performance or incentives for certain types of health workers, actually had negative side effects later on, and we weren't able to predict them in advance. So there's some good papers on health reforms in, especially around the Bamako initiative, health financing initiatives that were well intended at the time they were implemented, but within 5 years it was recognized that they were actually causing what's called perverse incentives. They were skewing the system in ways which was leading to negative impact on health worker motivation and performance. So in clinical research, there's less risk of stigma because people are individually consenting into the study. So if they decide, I don't want to be part of this, in principle, they can decide that already at the outset. Although we will get into the issues of challenges around that, because if you're being asked to participate in the study, and if you're a poor person in a country where participating in a trial might mean some benefits, even if it's getting care for your child, you're hard pressed to say no, right? So the issue of whether consent is really consent in those kinds of situations is a hotly debated issue, right? But in health policy and systems research, the risk of stigma is more for the groups, and there are reputational risks for institutions. So imagine we enroll 8 hospitals into a study, and we soon find out that there are 2 hospitals in those 8 that are really, in all aspects of the word, suboptimal. Performance is low, they're lagging behind in terms of, performance indicators, progress indicators. So by participating in that research, those 2 hospitals suffer some kind of reputational loss, right? because it's going to be clear that when those publications come out, even no matter how well you disguise it and you give them new names, there is an issue about drawing attention to suboptimal performance. Okay, so an example about how to deal with this. There's a study on health workforce challenges. So issues of shortages, which are leading to people being overburdened, which are causing strikes, etc. And the researchers need to face the concerns that the findings might be misused by policymakers to justify staff cuts. Okay, so there is a real risk when you uncover things that are related to performance and in any way constitute some sort of assessment of performance, that people could misuse this. And so in this case, the researchers preemptively address this by creating a dissemination plan that includes clear explanations of the study limitations and recommendations for equitable health workforce reforms. So it means that the researchers at the outset of their study are committed not just to ethical principles, but to moral principles, because they've got to think further down the line about how this could impact on health workers who may or may not face some repercussions from their findings. Okay, moving to the third principle, beneficence, do good. In clinical research, we talk about the benefits accrued by individuals, whereas in health policy and research, they're often gained by groups who are not directly involved in the study. So our focus might be on the system, but actually it's the surrounding community that's going to derive the benefit. So the question is how to balance the risks for one group versus the benefits for another. In clinical research, you have a principle called clinical equipoise. And equipoise relates to balance, and that should guard against a useless or an irrelevant study. Okay, you should be able in a clinical research study to really address and, if necessary, terminate the study if it is shown that this is not having any visible impact. So you will remember, for example, the trials on female microbicides some 15, 20 years back, okay, for HIV. So it was HIV prevention, was using gels, microbicide gels, and at one point all those trials were interrupted because they saw that they were not making a difference. So this is, of course, a big setback for the researchers who invest, certainly at that time, not anymore now, but lots of money into these trials. And it's also a huge setback for all of those participants who invest a lot of hope in their participation in this research. So while it might be easier to define that for clinical research, it is less easy to define it in a health systems piece, balancing risks for one group versus benefits for another. So in health policy and systems research, there's definitely the mandate that the study should only be undertaken if there's a reasonable expectation of meaningful outcomes. Okay, the last question is around justice. And here, justice is essentially around the way you choose your study participants. So in clinical research, the eligibility and the exclusion criteria are set. You have a definition of who you're going to include in your trial because they match the criteria that are needed to be able to meaningfully and in a robust manner assess whether whatever it is, whatever intervention, whatever drug, etc., is going to make a difference or not. In health policy and systems, sometimes we tend to overrepresent vulnerable groups because we want to ensure fair selection of participants. Okay? So in a clinical trial, you're not going to go out of your way to select people who are poor or who might be more malnourished. In fact, that might compromise your trial. Okay? Let's say you're introducing something, a drug, where there are known effects with malnutrition. So you're going to try to ensure that people are healthy, adequately nourished, above 18, and so on. In a health policy and systems research, it's the opposite. If I'm testing an intervention I want to make sure that an intervention is going to be accessible for some of the most vulnerable groups. I'm going to try to ensure some kind of equitable coverage. So I'll go out of my way, initially at the conceptual stage, to say, have I adequately mapped the surrounding community? Are there pockets of vulnerability of people who are not accessing the system at all currently that I need to take account of? Very different logic. Yeah? In clinical research, inequity is inherent to some randomization procedures. Okay, because you randomize your participants according to certain criteria, and you're specifically looking at differences. Okay, how is this going to work in X group versus Y group? So there's an inherent inequity. Now, inequity not in the sense of injustice, but those groups might be based on differential characteristics. And in health policy and systems research, you're aiming to avoid aggravating any existing inequalities. In a clinical research, community engagement is often not necessary, although you will see community engagement strategies that are linked, for example, to clinical trials, right? Because why? Because you want to get people on board. So I always say a bit cynically that the whole point of clinical engagement in trials is not really about engagement. It's about how do I make people more likely to say, yes, I'll participate. Not really engagement, is it? Whereas in health policy and systems research, that engagement is often necessary depending on the type of intervention that's being tested. In clinical research, the standard of care is often not clear, right? Because you don't know yet. You don't know whether this drug is going to work, whether this intervention is going to work, and therefore you don't know yet what is appropriate. Should we really be moving towards a shorter regimen? Should we be advising screening for all, this particular cancer for all women above 30 or not? So your standard of care is only going to be determined after you have the results of your research. Whereas in health policy and systems research, the standard of care is particularly relevant, especially for your control group. Okay? Finally, the dissemination of findings. In clinical research, you're obliged to report both positive and negative findings of a publicly funded trial, and you report them back to research participants. Versus in health policy and systems research, the whole purpose of the research is to make a difference to the system or to policy, and therefore you are disseminating not only at the academic level, but you're disseminating to policymakers, to decision makers, to communities. So when you think about dissemination strategies, you have to think a bit more broadly than you would for a clinical trial. Okay, example, I mentioned to you that South Africa has come a long way in terms of decentralizing DRTB care. So these are, when I was working there, they were still in draft form, these guidelines, and now they have policy guidelines which have been implemented. But let's say we conducted a Hpsr study and on decentralization, and we found that actually rural clinics lack resources. So in other words, they're not really ready to implement the policy changes effectively. So in this case, the researchers would need to ensure that that interventions address these kinds of disparities by allocating resources equitably and prioritizing support to under-resourced areas. In other words, the research recommendations, including how we conduct this intervention, need to take these inherent differences in readiness into account. Okay, in clinical research, you don't. You just say, boom, decentralized care is going to bring the same, we can prove, we can show you that administering treatment for people who have drug-resistant TB is effective, as effective if I deliver it through a nurse than if I deliver it through a specialist. But the health systems people are going to say, well, it depends on the system. If you have an environment that's conducive, that's supporting the nurse to be able to deliver it, all good and well. But in a health unit, in a facility where the nurse is not empowered and the resources are such that they're not ready to implement this, the research findings are not going to be sustainable or that pertinent to the local setting. Okay, so now we're going to move into something called everyday ethics. Okay, so you might be saying, good, now I'm already understanding the difference between clinical research ethics and health policy and systems research ethics, and I'm getting the sense health policy and systems research I need to think about a lot more. But now there's a different kind of ethics, which goes back to our questions of what is the difference between ethics and morals, yeah? And this is about ethical decision making during the research or during the implementation of the intervention. And it's the dilemmas and the day-to-day struggles that are faced by global health systems actors or global health actors while they're undertaking their work or their research. So what we're going to contrast, and we're going to do a nice exercise to show this, is that you might have followed all the nice formal bioethical guidelines, you submitted your protocol to ICMR, you've ticked all the boxes. You're ready to go. But suddenly in the field, you're encountering all kinds of things which you didn't anticipate, which are testing your own ethics and your own morals. And given that you yourself are a member of the cultural or the social community within which you're working, you're going to have to balance these two things. Okay? So this is really going beyond formal guidelines to address context-specific situations. And most courses on ethics, most training on ethics is not going to talk about everyday ethics. Yeah, they're just going to talk about the formal principles. Bang, you do your protocol, you submit it, finished. I can now rush into the community, collect data, collect blood samples, off we go. Yeah? But this is about balancing interests of different kinds of stakeholders, policymakers versus communities. Where's your loyalties? Yeah? And those loyalties can be split over time. It's managing the power dynamics in researcher-participant interactions. We've already talked about that, yeah? Holding a key informant interview and about the different role that you might take. And you might get yourself into situations there which are inherent to the power imbalance, but also situations where somebody's a bit too friendly with you and crossing some kind of boundary in terms of both divulging information, which you really shouldn't, you can't suddenly put earmuffs on. So how do you deal with those situations? That is as much an ethical situation as the formal ethical situations, but it is contingent on your moral judgment in that moment, right? It's adapting to ethical challenges in real-world settings, such as unforeseen risks to participants or inequitable resource distribution. So I like this quote. It's from a paper on the anthropology of everyday ethics in healthcare. And they say, think about this. Every day, at home or at work, we make many little decisions about what we will do, informed by ideas on why this is good or why it would be good. Or we're subtly urged to do things in certain ways, various pressures to respond to emails or phone messages or by apps that tell us we haven't taken enough steps per day. For many decisions, we've developed routines because we believe inherently they're good, right? Brushing our teeth, taking the kids to school, etc., etc. Interacting with our elders in a certain way, interacting with our juniors in a certain way. So those values, those everyday moral values are embedded in our technologies, that we use, including the rise of AI and the rise of using the internet, social media, etc. And they tell us what they measure is good or demand action. So we're constantly reminded of that, right? There's some kind of assessment of our performance, our fitness, our weight, our behavior, etc. So these are, one could say, solidified ways of doing good without having to reflect every time on whether we do these things or not, right? Everyday values, their guises, the activities, the relations, the evocations are the subject matter of everyday ethics, okay? So what I want to encourage you as researchers, no matter what kind of research you're doing, is to always reflect on that, is that you are juggling formalized ethics, procedural ethics, or what is known as normative ethics, with everyday ethics, okay? Which are the kinds of dilemmas that arise in the conduct of the research, in through your presence in a particular system or a community. Okay? So, some of the things which Solomon, I think, is going to talk to in a very visual way, because he's going to talk to you about things that arose for him in his field work, are around power dynamics, navigating the hierarchical relationships. It's about stakeholder engagement, meaningful and equitable participation without tokenism. Okay, so we say we're doing stakeholder engagement. We say we've done our job. We had our meeting, we organized a few people from the community. That was it, community engagement. What did we do? We held a 20-minute lecture at them and told them what our research was about. Is that meaningful community engagement? Probably not, right? So how do you do that without tokenism? So you might say, well, you just offer them soft drinks and a round of bakarwadi or whatever, right? That's not enough. So meaningful engagement, unfortunately, has been very corrupted. So I just came from a country, Uganda, where sadly, the research environment has been so corrupted by the way foreign donors work that if you try to hold a stakeholder engagement meeting, the only way you're going to get people coming to your meeting is to pay. And the payment, I kid you not, is not a question of 50 rupees, 100 rupees. It is 50 euros per participant is what I paid recently for a stakeholder engagement meeting. Okay, so 50 euros is approximately 50 times 80 is about 4,000 rupees per person. Okay, I was gobsmacked. And I said, what is this? And they said, there's nothing we can do. The expectations, the bar has been set by USAID. I said, yeah, but this is nonsense. USAID is now out of, no wonder they're cutting their foreign aid. This is ridiculous. And they said, what do you want? Do you want an empty room with one person who comes because they have because they're actually... So, challenging situation, challenging ethical situation. Because I was saying, no, we offer drinks, we offer we offer engagement throughout the research. And they were saying, no, it's not going to work this way. This is what people from the Ministry of Health expect. So, informed consent. Challenges with obtaining meaningful consent in a complex system or a hierarchical setting. So what does informed consent mean when people feel in some ways they have to participate? Okay, especially if they're on lower levels of the health system and you round them up and you say, okay, I want to do a focus group with ASHAs. And you know it's going to be somebody else who organizes them, some kind of supervisor, manager, matron, whatever it is, who rounds them up, puts them in a room. Okay, please go ahead, do your focus group. And you say, okay, thank you. We're going to just take a consent form. You're all voluntary consenting to this. Is it really voluntary informed consent? Do you really give them the option to say, look, you can leave at this point? Or do they feel compelled to attend because the supervisor has told them, look, exceptionally, I'm giving you 1 hour to participate in this research. You better be happy with this. Okay? So think about this. It's very tricky, but you should be always reflecting on, you should have moral doubts and moral questions about what you're doing, each step of the research. Confidentiality, balancing data privacy with transparency in health systems research. Now this is challenging, right? Because on the one hand, you want transparency. You're trying to uncover something about systems, information systems that might not be working. But in doing so, there's a real danger that you're exposing parts of the system that might be really quite sensitive. So you're exposing the fact that they're collecting data on people in a way that is revealing their identity, or that the records aren't, there's a leakage of security, et cetera, et cetera. So those things raise lots of issues around what should be kept private versus what do you need to look at because you need to assess the system. And then something that Solomon will raise in much more detail is this issue that we already talked about yesterday, which is when you're a participant versus a researcher, you have two different roles. So you might be just getting very comfortable. So for example, in Ajay's case, or anybody who works in the health system, he might be quite privileged in terms of his access to the research field. It's easier for you to maneuver your way in, but you're going to have to balance that, right? You say, Okay, no, I have to step back. I'm a researcher now. Yeah? So also being a researcher versus an advocate. Yeah? So when you do activist research, in principle, you're already driven by a perception that there's an injustice, and you as a researcher need to give voice to people who don't have a voice. But how much of that advocacy is actually biasing your research? Yeah? If you've already decided that this particular tribal group is very disadvantaged, is suffering, etc., sometimes, unfortunately, that bias, which often may stem from the fact that you as a Western researcher have decided these poor people, they're very disadvantaged and I've got to do something, I go out there, I'm doing my research, and later you find out actually it's not the case. Okay, has also happened. So those are the kinds of everyday ethical challenges. What we're going to do this afternoon is we're going to start preparing an exercise whereby we're going to consider each of your topics, and we're going to think about some of the everyday ethical challenges that might arise. And you're going to develop over the course of the afternoon a skit where you're going to perform the situation. One person's going to be a narrator, and they're going to narrate what's going on, and then you're going to, how do you say? It's not fast forward. What's the opposite of fast forward? Rewind. You're going to rewind, and then you're going to present the strategy to deal with that situation. Okay? So it should be fun, hopefully, and you have enough time to develop that. But we're going to stop there and just check whether you have any questions on the materials so far.